Hi, my name is Luciano Costa. I'm a professor of medicine at the O'Neill Comprehensive Cancer Center at the University of Alabama, Birmingham. At this 18th IMW, I'm presenting on behalf of my colleagues from the COMIT Consortium, the primary endpoint final results of the master study. So this study was a single-arm, multi-institutional trial that we performed in the United States for patients with newly diagnosed multiple myeloma, where we test a combination of Daratumumab, Carfilzomib, Lenalidomide, and Dexamethasone. Contrary to most studies where patients receive a certain therapeutic plan, regardless of their depth of response, what we did in the study is we adapted the duration of therapy according to the patient's response. So patients received 4 cycles of Dara-KRD induction, an autologous transplant, and then up to 8 cycles of Dara-KRD, depending very much on the clearance of MRD. So MRD was assessed by next-generation sequencing at the end of induction, post-transplant, and then if patients require consolidation after 4 cycles and after 8 cycles of consolidation. And therapy continued until patients has 2 consecutive MRD results being negative. That means less than 10 to minus 5, according to IMWG criteria and the international harmonization for MRD reporting. Also in this trial, our outcomes reported for MRD are by intention to treat. So all patients are in the denominator. And what we found first is not surprising. Dara-KRD is a very active regimen. We had over 99% of response. And of those 123 patients that we recruited, the patients were somewhat older and sicker than the patients that are seen in other newly diagnosed trials with quadruple therapy. We did not have an age limit, so 20% of the patients were older than 70. And we allow patients with ECOG of 2, so 20% of the patients had ECOG performance status of 2. We also had an enrichment for patients with high-risk cytogenetic abnormalities. As a consequence, we end up with about 43% of the patients being standard risk, 37% having one high-risk abnormality, that means 17p or 414 or 1416, 1420, or gain amplification of 1Q. And 20% of the patients being what we call ultra high risk. Those are patients with 2 or more high risk abnormalities. So in the results, we had overall at 80% of the patients achieving MRD negativity less than 10 to minus 5. And surprisingly, that rate was similar between patients with 0, 1, or 2 plus high-risk cytogenetic abnormalities. It was respectively 78, 82, and 79%. If you look at 10 to minus 6, the overall MRD negative rate was 66%, and there was 64, 73, and 58% according to 0, 1, or 2 plus high-risk cytogenetic abnormalities. If you look at the International Myeloma Working Group standard response assessment, the overall response rate was over 99%. 86% of the patients achieve a CR or better, and including over 89% of the patients who were already in VGPR or better at the end of induction. The regimen was relatively well tolerated. We had the most common severe adverse events were thromboembolic events and pneumonia. So from this study, we conclude that, yes, you can do MRD response adaptive therapy in a multi-institutional setting that was applicable to 96% of the patients. And I think we had overall 72% of the patients who met that criteria to go on observation and MRD surveillance. So this approach of a highly active upfront regimen enables us to now having this approach of MRD surveillance without maintenance therapy. And I think future trials should look at possibility of de-escalation of therapy for patients who are early achievers of deep response. Conversely, we saw a few progressions on therapy, particularly among those patients with ultra-high-risk disease. And for those patients, I think it's going to be important that new upcoming studies introduce novel therapies, particularly novel immunotherapies that go beyond quadruple therapy as we have currently established.